It gives me great pleasure to welcome you to the next segment of CAP's annual Professional Development Day, or what I prefer to call the main event. Some of you joined us earlier for CAP's annual meeting and were able to hear and see our land acknowledgement. Nevertheless, some of you have just joined us, and as a result, I would like to once again, in the spirit of truth and reconciliation, offer this land acknowledgement and to highlight that equity, diversity, and inclusion is one of CAP's key priorities in the recently adopted 2022-2025 strategic plan. Also, to note for those of you just joined us for the main event, it will be facilitated by Nina Blake of Matchbox Virtual Media. Should anyone run into technical difficulties, please contact the Matchbox team via email at support@matchboxvirtual.com or contact them through the chat feature on your device. Nina, we appreciate you and your team being available to us as technical support today's event. Once again, everyone, thank you for joining us today. Evaluating and intervening with those who are at risk for suicide is stressful, complicated, and challenging for many psychologists. Notwithstanding the recent slight decrease in the number of actual suicides during the post-pandemic in both Canada and the United States, an increase in the number of individuals reporting symptoms of anxiety and depression has been reported. This is also true for those who've reported considering suicide. According to CISR 2020, almost twice as many adults reported considering suicide in the previous month than in 2018, lending credence to addressing the issue beyond simply reported symptoms. Notwithstanding the overall trajectory in completed suicides, Statistics Canada reported in 2021 an average of 1 in 10 Canadians dying from suicide each day. In Alberta alone, 523 individuals died from suicide in 2021. The rate of suicide is 5 to 6 times higher for Indigenous youth, and more than half of LGBTQ2S+ youth, ages 14 to 25, reported having thoughts about suicide. The fact remains that even one death is too many, and that there is a significant multiplier effect for those who have been impacted by the aftermath. Suffice to say, few of us have not personally or professionally been affected by suicide. Historically, many psychologists have believed that predicting and intervening with suicidal clients is fraught with uncertainties. Today, the outlook is much more promising as advances in both assessment and treatment have been reported. This is also true for special populations and specific age groups. Psychologists can now more confidently turn to empirical research to determine the reasonable standard of care in both assessing and treating those at risk for suicide. With this in mind, it gives me great pleasure to introduce Dr. David Jobs. Dr. Jobs directs the Suicide Prevention Lab at the Catholic University of America in Washington, D.C. He is also an Adjunct Professor of Psychiatry, School of Medicine at Uniformed Services University. He is the author of 7 books and numerous peer-reviewed journals. Dr. Jobs is the past president of the American Society of Suicidology and the recipient of various awards for his scientific work, including the 1995 AAS Shneidman Award, the 2012 AAS Dublin Award, and the 2016 AAS Linehan Award. He has been a consultant to the Centers for Disease Control and Prevention, the Institute of Medicine of the National Academy of Sciences, the National Institute of Mental Health, the Federal Bureau of Investigation, the Department of Defense Veteran Affairs, and he now serves as a highly qualified expert to the U.S. Army Intelligence and Security Command. Dr. Jobs is a board member of the American Foundation for Suicide Prevention and serves on this board's scientific council and is the chair of the Public Policy Council. He is a fellow of the American Psychological Association and is board certified in clinical psychology. Dr. Jobs maintains a private clinical and consulting practice in Washington, D.C. and in Maryland. During Dr. Jobs' presentation and the panel presentation that is to follow, Dr. Troy Jantz will monitor the chat box, and if time permits, he will pose a few questions.
Okay, so welcome. I am delighted to be with you today here from Bethesda, Maryland on a really beautiful, like almost first day of fall day that we've had over a pretty miserable summer. I am so pleased to be with you and have this chance to talk to you about this important topic. I've been to Alberta and know how beautiful it is, and I'm very grateful to have this chance to share these thoughts. I'm going to go for about an hour, and then if all goes well, we'll have about 15 minutes for Q&A that Dr. Jensen will be fielding. And I'm so grateful for the invitation to do this, and hopefully you find it helpful. I am talking to you today about innovations in clinical assessment, management, and treatment of suicidal risk. And this is really near and dear to my heart. This is my university at Catholic in Washington, D.C. These are my various disclosures. They also contextualize a bit of where I'm coming from in the research that I do. I'm funded by our National Institutes of Mental Health and our National Institutes of Alcohol and Alcohol Abuse. I have book royalties. I'm a founder of a training company, and I do a lot of work with our Department of Defense and our VA system. So when I talk about that research, I'm talking on behalf of myself as a citizen and not on behalf of the US government. So I oftentimes start with this particular image because it really captures so many of the things that we wrestle with as clinicians and systems of care in our respective nations around suicide risk. This is an individual who's in a very dire situation on one of the towers of the Golden Gate, surrounded by first responders. And what I often do when I start a workshop, I'll say, what can you imagine is going on in this person's mind as they cling to this tower of the Golden Gate Bridge? And what are the respective roles of each of these individuals who are there to help prevent his suicide? So I want to begin the discussion actually in a little bit of a historical context, because history does often bear relevance to the present day. I am actually reading a really fascinating book called Desperate Remedies. I'd highly recommend it. Psychiatry's Turbulent Quest to Cure Mental Illness. It's a fascinating discussion of sort of the really truly desperate and provocative things that were done in the name of curing or mental illness, ranging from cutting out organ systems, infusing turpentine, electrifying the entire body. So, we really have this sort of interesting history that I think bears right up to the present day. If you aren't familiar with the world's religions around exorcism, all the major world religions have some version of exorcism. Christianity, of course, this is a middle picture here is a form of Catholic waterboarding. Here's the devil being driven out of this poor soul's mouth. And then across Islam and Judaism and Hinduism, exorcism is universal. And it was our explanation of understanding abnormal behavior and who do we not understand and how do we explain it? It was true that for really decades, many years, that people that were mentally ill were deviants, and they were put out of sight and out of mind because they were disturbed and they were disturbing and disruptive to society. Treatments were pretty crude. Bloodletting never was therapeutic for anything as far as I can tell. Trephination, or the drilling of a hole in the cranium, is absolutely not therapeutic and definitely leaves a mark. So this is sort of a backdrop for which I think is relevant for our discussions today. Now, in theory and philosophically, a lot of this changed with this gentleman, Philippe Pinel, who was a psychiatrist or physician at El Sapatier, an asylum for women in Paris, who famously launched the notion of moral treatment and the asylum movement in France, which then propagated throughout Europe and the UK and ultimately came over to the United States. The philosophers of their day thought it was cruel to be imprisoning and chaining and shackling people who were mentally ill. And they venerated these individuals and meant to create sanctuaries, or what we call asylum. But we don't really think or have much positive imagery when we think of asylums, both then and even to some extent today. We warehoused people for many years, and there was very little therapeutically going on beyond just controlling behavior. So lots of use of restraints, lots of use of electricity, a little bit more advanced use of it in electroconvulsive therapy, and surgeries, cingulotomies and lobotomies. This is a gentleman who toured all over the Eastern Seaboard named Dr. Freeman from St. Elizabeth's Hospital here in Washington, who did ice pick lobotomies, where he would basically tap an ice pick instrument into the orbit of the eye to penetrate the prefrontal cortex, and then would swish around the tool, and lo and behold, significant behavior change if people didn't die. So you just think, or I do at least, of these days when people didn't know what to do, and also how desperate it was to do anything to control behavior. If you had an assaultive patient in a unit, someone who was biting themselves or assaulting staff, something like a lobotomy would be very profound, although it was very injurious and phased out in the late 1960s, basically. Now, my point is that a lot of people have the mindset or the mentality, I'm going to refer to mindset here, of where a suicidal person should be. And that would be in a hospital. And we know in my country, in the US, that hospitals do have suicides. So it's not as suicide-proof as we might like to think. We also know that there are people like Marshall Linehan and Matthew Large. Matthew's a psychiatrist in Melbourne, Australia, have strong views about hospitalizations causing suicides, which Matt calls nosocomial suicides. And Marcia herself, very much anti-hospitalization. She, in her own lived experience, was hospitalized often as a teenager, was in seclusion for 3 months during one of her hospitalizations. So things that are shocking to a lot of people is this paper, for example, that a readmission of an inpatient adolescent is associated significantly with a more severe suicidal trajectory and increased suicide attempts. We know that there is a limited amount of actual genuine care outside of medication, at least in the United States, but I also think it's true in Canada as well, and other countries in the Western world. What's typical is a couple of brief groups that patients don't find very helpful, and almost unanimously medications. There are exceptions, but what's not an exception is that hospitalizations are associated with significantly increased risk post-discharge. And this has been replicated all around the world. 5% of post-discharge suicides occur within a week. Others occur within 1 year. And there's also evidence that patients avoid talking about suicide because they don't want to be hospitalized. So if you're keen on hospitalization, I have no problem with that, except we need to make our hospitalization more suicide focused. And I'll have a lot more to say about that as we go. This notion of fixed mindset is something that Carol Dweck talks about. And this is a notion that we have kind of a way that we want to look at things, not open to feedback or empirical data. And I think we have that fixed mindset about hospitalization. And I think we have it about medication. That we think that medication must do more than it actually does. There's unreplicated RCT evidence that lithium works, but a meta-analysis came out just this week of 14 or 24 studies, I can't remember which, basically showing lithium has little to no effect on attempt or suicidal behavior. Clozapine in the United States has been approved by our Federal Drug Administration as the only medication without a single replication. And then you have as many SSRI studies as that are helpful as where it's harmful. So we want medicine to be able to do more. It does a lot for psychosis and perhaps some other conditions that we're familiar with. But with regard to suicidal ideation behavior, the data is either non-existent, mixed, or quite limited. One could argue an exception to this is ketamine, and ketamine does have a dramatic impact, but it does only about half the time, and the effect is not very attenuated over time. It might be a matter of a few days. I did an interview for Men's Health, and as you probably know, men are much more at risk for suicide, death by suicide, than are women. In the US, 3/4 of our suicides are middle-aged white males. So it's a very robust gender effect. I talked to this journalist who wrote this piece in Men's Health for about 3 hours, and she really got it. And then when the piece came out, help is on the way in the form of ketamine and a stage 3 FDA trial of a medication that's still not in market. What is up with this? We just, I guess, want to take uphill, and we just want to think these medicines are more powerful than they are, at least with regard to ideation and behavior for suicide. So What are the challenges to being at the cutting edge of this? Why are you here, hopefully trying to learn something new? Well, the status quo is hard to change, and there's a lot of magical and wishful thinking. There's also in the United States, and probably is better in Canada, I'm almost assured of this, that our health plans don't really sufficiently cover effective suicidal care. So if you know dialectical behavior therapy, we don't typically cover phone consultation, which is a key element of DBT. And until very recently, arguably in the DSM-4 TR, not my favorite diagnostic manual, we haven't had a suicide diagnosis. In the States, that's what drives how we get paid and who gets paid. Clinicians clearly have fear of losing patients. Americans are obsessed with malpractice. It's actually a very rare event, but they end up practicing very defensively, hospitalizing people that really could be handled much more easily and effectively on an outpatient basis, defensive practice. Most clinicians, and I bet this is true in Canada, are not trained in evidence-based interventions or assessments. Even what you're doing here with me today in this keynote is out of the ordinary. We all have, me too, share a clinical care bias that this is the only thing that's going to work. Of course, that's not true. So I'll talk more about that towards the end. And the vast majority of people who are suicidal reject us, probably upwards of 70%, depending on the country. So a relatively small subsample of people are seeking mental health care. And there's a public relations battle. I just talked to a journalist from the New York Times yesterday, who was talking about a family member who went to the emergency department, was there for 12 hours, was finally admitted for a 6-day hospital stay, and then was discharged to a step-down unit. Pretty intensive care. And he said, I don't really think it helped her. In fact, I think it made things worse. And I said, yeah, welcome to my world. I think a lot of this care we wish was more effective than it is. And there's a problem with people not knowing what actually does work, which is definitely why I'm here today. So when we look to the theory and the models in our field of what sort of gets our attention in terms of thinking about suicide risk, there's a definite sort of perfect storm model idea where different forces come together. Ed Shneidman's cubic model, Thomas Joiner's interpersonal theory, perceived burdensomeness and thwarted belongingness interacts with acquired capability. Rory O'Connor in Scotland talks about the IBM model, the integrated motivational model, more complex, focused on entrapment, defeat and humiliation, that ultimately leads to suicidal behavior, the contribution of genetics, of the environment, and of life events. In British Columbia, David Klonsky has developed with Alexa May ideation to action, a 3-step model that differentiates ideation versus the tipping point to get us into attempt behaviors. And then finally, there's David Rudd and Craig Bryan's fluid vulnerability model that looks at both acute and chronic suicidal risk. I share these just as a brief overview that we've got a very vibrant community of scholars thinking about different ways that are relevant clinically and also that guide a great deal of our research as well. I would also note that people with lived experience, from Marshall Linehan all the way through, are making a huge impact on the field. They're basically not happy with the experiences they've had in traditional approaches to suicide risk that many of us are probably familiar with very directly. Hospitalizations, use of medications, use of restraints. A lot of these individuals are making a very loud statement about not being happy with the status quo. Also, in our respective nations, there are policies, and these policies from our Joint Commission, from our Zero Suicide Initiative, from the Action Alliance, which is our national body that guides federal legislation and thinking in suicide risk, and how we think about working with suicide risk. Policy is really hot right now. I'm the chair of the Public Policy Council for American Foundation for Suicide Prevention, and we're very actively involved in developing policy. For example, we now have a 3-digit 988 number for our national lifeline, and we've seen a commensurate increase in calls to 988 since we made the number more simple. When COVID occurred, we had large healthcare systems basically saying we're not going to ask about suicide risk because we're not in the same physical location to stop them, which I thought was crazy. Of course, you can do remote telehealth work around suicide risk. You just have to be thoughtful about informed consent, have third parties that perhaps potentially can reach out or be involved in case there's an emergent scenario. So these policies have been shaping and influencing a lot of the research, a lot of the federal dollars, and a lot of the funding that's now being allocated in our country. I'm sure the same is true for Canada. I'm a little bit American-centric. I'm sure that's shocking to you. I do know a bit about Canadian suicide, definitely about the Indigenous challenges that our country faces as well. But you'll have to forgive me for being a little bit focused on what I know best, which is our own national struggle. All right, so the process of successful engagement begins with screening. And there are 3 screeners that are probably the most popular, and they're the most popular because they're free. And this is true, I think, at the world level. There's the PHQ-9, which is a depression screener with 9 questions. There's a Columbia Suicide Severity Rating Scale developed by Kelly Posner and her colleagues. And there's the Ask Suicide Screening Questionnaire developed by Lisa Horowitz. These are popular because they're online and they're free. But the PHQ-9 is really actually a flawed depression assessment tool. Look at question number 9. Thoughts you'd be better off dead or hurting yourself? That's not a suicide question. Now, admittedly, Greg, I'm blocking on his name. I'll come to it. There is Greg Simon is a psychiatrist in the Kaiser system in Washington State. He's done some really nice work around the PHQ-9, but it just misses too many people that are suicidal. So we recommend not using it. It just misses too many people. And this is a paper that we published about that fact. So it's a perfectly good screener for depression, but it misses too many people that are suicidal. For my part, the Columbia is a decent tool. It's a little bit more complex. A lot of patients don't love it. Clinicians are mixed. It's got fairly good psychometrics, but I'm partial to the ASQ, which was developed originally on children and teenagers, and we have since normed it on adults as well. 4 simple questions, and a 5th question being asked. This has been used in medical surgical environments, in different kinds of clinics. To me, it's a great tool to get the ball rolling, and it's available online. So if you just look up the CSSRS or ASQ, you'll get different resources around those to download. So once someone's identified, then we have assessment. And what we know from the research literature is that the vast majority of clinicians rely on interview-based assessments. These are pictures from the ASHI conference that was held for a number of years in Switzerland, and also more recently in Vail, Colorado. 10 different conferences, all looking at how do we work with a person who's suicidal, where the dynamic has the potential, have you thought about suicide? Yes, I have. Well, you can't kill yourself. Oh, yes, I can. No, you can't. Do you want to bet? I do. And there we go, adversarial relationship. So here's a book that we published from the ASHI model of how do we form a relationship with someone who's thinking about suicide in a way that we can actually not be in an adversarial role, but in a more collaborative therapeutic alliance. The ASHI conferences came to an end in 2019 before the pandemic. I think they're basically done, but it ran a really important course, and it drew a lot of people from around the world to really looking at how do we do the therapeutic interview in a way that's therapeutic, in the way that forms an alliance around the issue of suicide risk. Now, as psychologists, you must appreciate that there are a number, actually hundreds of tools that have been developed and well test constructed with excellent validity and reliability that clinicians, we know because we did a study, refuse to use. Now, partly that's because of they're non-proprietary, so they're proprietary, so you have to pay for them. Partly because they give you scaled scores that don't necessarily translate into clinical work. And what I think is fascinating about this is the work of the late Professor Paul Meehl, who's at the University of Minnesota, who studied the difference between actuarial assessments, tools like this, that admittedly have a limited predictive validity because you mostly are not going to predict people that die or attempt suicide, but otherwise have excellent psychometrics, with the preference actually being for the clinical interview. Clinicians are overconfident about their clinical gut judgment. In every study that Professor Meehl published, he showed that actuarial assessments were superior to clinician gut judgment. The exception, of course, would be us, the 960 of us on this webinar who are certain that our clinical judgment is going to beat a tool. What I would say is that you can be additive and you can be a much better clinician by using both the tool and your clinical judgment. Now, machine learning is super hot. It's either beloved or hated, depending who you talk to. The idea here is that you take a lot of data, for example, medical record progress note from the VA system, and you analyze thousands of charts. And you look for algorithms that differentiate, for example, a sample of veterans that died by suicide versus a sample of veterans that don't die by suicide. So that machine learning algorithm is now being used in our VA system. So if you're sitting with a veteran who matches on that algorithm, there's a flag that comes up in the electronic medical record cueing you to do an extra deep dive on suicide risk. It is okay, good, solid retrospectively, where it's not as convincing as prospectively. And that is the sort of the bane of a lot of suicidologists' existence, is the elusive nature of predicting future behaviors that are a low base rate event. This is a study that was conducted by David Brent's group at Western State, identifying different populations of suicide ideators from people that had never had suicidal thoughts, putting them in an MRI and asking them about suicide risk. And these circled areas are areas that light up differently when asked about suicide for people that are suicidal. So this is a really exciting area of using magnetic resonance to look at the sort of the different brain physiology of people that are suicidal and those who are not. So the kind of combined machine learning, magnetic imagery line of research. Now, we can screen, we can assess, and then to me, the next big step is managing acute risk. And to this end, we have struggled in our nations to let go of no suicide contracts, no harm contracts. I was in Winnipeg a number of years ago where no harm contracts were widely used, and people did not like my feedback on the idea of not using no harm contracts, at least at this conference. They were insistent that a no harm contract, promise me you won't kill yourself between now and next week, sign here. If you refuse, we'll put you in the hospital, was somehow not an effective intervention. There are now one randomized control trial, one case control trial that show that they absolutely are not effective. If you think about it for a minute, promising what you won't do versus what you might do should you get into a crisis moment makes just so much more sense. So this is the Stanley Brown safety plan developed by Barbara Stanley and Greg Brown. It focuses on warning signs, internal coping strategies. It walks the patient through things that you could do should a suicidal crisis occur. A variation of this theme is the crisis response plan developed by David Rudd and Craig Bryan, which does a very similar thing, but on an index card written in the patient's hand. And when the patient writes it and they laminate it, there's better encoding and better retrieval and better memory for the items on the card. They are very similar. And in the latter case, Craig Bryan did a really convincing randomized control trial showing that a single touch crisis response plan reduced attempt behaviors by 72% in comparison to no harm contracts. So the data is irrefutable. These are much more effective than having someone promise what they won't do. Recently, in the last year or so, there was a meta-analysis of 6 safety planning type interventions from a European team. And across these 6 studies, we saw a significant effect for reducing attempt behaviors, but a lot of variability on reducing suicidal ideation. And this is a big point of my talk today. There are going to be interventions that reliably reduce suicide attempt behaviors, but not necessarily ideation. There are other interventions that reduce ideation, but may not reliably reduce attempt behaviors. So one of my ideas is that we match different treatments to different needs. Now, a big aspect of stabilizing our patients in both our countries is relying on a crisis line or a text line. In the US, I need to update my slide. In July, we moved over to 988. The calls have increased. We already had capacity issues with a number that nobody could remember. So we're going to see what happens as this number 988 gets more widely used. We also have a private national text line that's quite good. My son actually is a volunteer in the national text line. He's an engineer. My wife worked on the National Lifeline. She's a lawyer. So these are good people who are well-trained. And in the case of the Lifeline, Maddie Gould's research at Columbia, John Califat, Brian Mishara up in Montreal have shown that thoughtful, quality crisis care delivered telephonically can make a difference with people that are suicidal. A related area is lethal means safety. And for us in the States, this is all about firearms, but also medications or putting barriers up in high places where people might jump, or other kinds of restricting access to lethal means. And what we know from Matt Miller's work and Kathy Barber at Harvard is that when we block a certain lethal method, say a high bridge, where there's a fence put up, there's not method substitution. People don't then just flip to another equally lethal method. So in the stabilization space, removing access to lethal means and providing these resources, to me, is sort of a given. That would be sort of a no-brainer. What's interesting is oftentimes I'll hear people say, oh, well, we gave it Columbia and we did a safety plan. We're good, right? And I'll say, well, you've got the process started, but you're not treating what makes this person suicidal. That's a whole different discussion. I would say the single biggest thing you can do to decrease the dangerousness of the situation is to secure lethal means. This is a fascinating discussion. I won't belabor it, but I will say in Bern, Switzerland, there is a palace where people would jump off. It's now been turned into a national park, and people would dive off this palace. It's a patio basically, but it's ornate and beautiful, to their death. Conrad Michel and his friends who work there in Bern put up a netting system so that people dive off that patio, that veranda. They're caught in the netting and their lives are saved, even though you can walk down to the end and dive off the side. It's a fascinating discussion about ways that we've stopped people from killing themselves where they don't necessarily. In BC, we have a bridge over the Calvert Street that goes over Rock Creek Park, where they put fences up in the 70s, where everybody was jumping off back in the 70s. And it stopped our suicides off those bridges, even though you can walk 300 feet the other way and dive off the Duke Ellington Bridge just as lethal. So lethal means discussions are really, really crucial. We had a soldier in one of our clinical trials of my intervention who had a stash of pills. The clinician actually interrupted the session and had to go back to the barracks to bring back her pills. And it was a lot of pills. And right now, by virtue of his taking possession of this this is polypharmacy at its worst, she, in this case, is a person who's much less at risk by virtue of securing these lethal means. So I've alluded to this, but this is something that, and here I look exactly the same, I know, 27 years ago, thinking about this idea that not all people who are suicidal are the same. From a clinical standpoint, they have, for example, different outcomes. In a small sample back in the day, we were looking at counseling center students, some who responded quite quickly in the course of routine counseling center work, others who dropped out, were chronically suicidal, or were hospitalized. This is a paper I published in 1995 with this audacious notion of prescriptive treatments, that someday we could perhaps match different treatments to different kinds of suicide risk. One particularly hostile reviewer said this was a pipe dream and it would never happen. I will show you where we are today and take a little bit of smug pride in saying we have actually now begun to realize this dream. All right, so treatment is often overlooked. How do we actually treat suicide risk? And how do we think about that? A lot of us were raised in a model where you think of suicide risk being a symptom of depression, a symptom of schizophrenia. Treat the depression, treat the schizophrenia, and ideation and behavior go away. Actually, the research does not support that. What the research supports is targeting ideation and behavior as the focus of treatment, independent of diagnosis. And the king of the hill is dialectical behavior therapy. And I'm sort of skipping a slide here. Let me back up. We have over probably 100 at this point, RCTs, focused specifically on ideation and behavior. And as I alluded to earlier, no support for inpatient care, lots of data that there's increased post-discharge risk. There's a handful of treatments that have a single randomized controlled trial. And we all know from COVID that randomized controlled trials are crucial to proving something like the vaccines are effective, and that we need to replicate those trials, and we need independent validation. And so when we really raise the bar to that highest level, we have actually just a handful of interventions that have been proven to be effective through randomized controlled trials, that have been replicated, and that have been also the same results found by independent researchers. So it's not the same clinician or the same developer finding proof of their own intervention. As I alluded to, dialectical behavior therapy is absolutely number one. Now with 44 randomized controlled trials, amazing. I was just in Copenhagen at the European Symposium, and Lars Mellem did a really compelling talk and mentioned the 44 RCTs. So we really do have an explosion of research around dialectical behavior therapy. There are two forms of cognitive therapy that are specifically focused on suicide. There's the collaborative assessment and management of suicidality, and the CAMS approach that I'll talk a bit about because that was developed in my lab. And then we'll talk a bit about caring contacts. So Marsha Linehan is a professor. She was a professor at the University of Washington. She's now in retirement and enjoying her hard work over many years. She's the creator of dialectical behavior therapy, by far the best proven intervention for suicide attempt behaviors and self-harm. Not necessarily on ideation, however. It's hard to explain DBT in a brief overview. 4 major components: skills group, individual therapy that focuses on the skills, phone coaching, and a team approach to doing treatment with high-risk populations. Marsha, among many things, invented the notion of a chain analysis, that a behavior doesn't occur out of the blue, that there are many cognitions and feelings that lead to that behavior. Each link in the chain is a possible moment for intervention, or a possible point of intervention. And this is just one of now dozens of studies showing that DBT reduces attempt behavior, in this case compared to expert treatment in Seattle, and also reliably reduces self-harm behavior compared to expert treatment. The late Dr. Beck, who passed away a year ago last summer, was the developer, along with Greg Brown, of the cognitive therapy for suicide prevention intervention that was famously published in JAMA in 2005. CTSP is a 10-session intervention that focuses on the suicidal mode. And Tim and Greg did this randomized controlled trial, one of the really famous studies of my field, where they took 120 patients in a medical center in Philadelphia and randomized them into 2 groups. Both got case management, which is a huge intervention for suicide risk, but the experimental group got 10 sessions of cognitive therapy and demonstrated a 50% reduction in attempt behaviors in comparison to control care. And even though it's cognitive therapy, did not touch suicidal ideation. David Rudd, who is recently the president of the University of Memphis, is now just a professor at Memphis and so happy to be back in the field and no longer running a university. He's one of the leaders in our country in suicide prevention. His colleague, Craig Bryant, who's now at Ohio State University, developed, I think, a first cousin of CTSP that they call brief cognitive behavioral therapy. Instead of safety planning, they use a crisis response plan, a little bit different focus in the suicidal modal model that Aaron Beck developed and David Rudd further elaborated. They did a study with soldiers at Fort Carson in Colorado and demonstrated a 60% reduction in attempt behaviors. So we're seeing really effective suicide-focused interventions that reduce attempt behaviors. But again, this intervention did not reduce suicidal ideation. So this is the idea that Dr. Beck and then David followed up and elaborated of the suicidal mode. They'll get a whiteboard that they put in their office with the patient where they identify your predispositions, that history or your vulnerability that might be relevant to you becoming suicidal in the present day. They would then identify your triggers that are specific to you of what pushes you over the edge that then activates what they refer to as the suicidal mode. Very specific cognitions, very specific behaviors, very specific emotional affective responses, and of course, change in physiology. That's highly interactive. And naturally, when you are in this incredibly dysregulated, upset state, and your limbic system is on fire and the amygdala is highly activated, the prefrontal cortex is basically offline. So a lot of the effective interventions, including DBT, including CAMS, I think are really meant to help the patient recognize, I'm getting into trouble, I need to re-engage my prefrontal cortex. It's not that overt, but when you pull out a safety plan or pull it up on your phone and engage with that, you're now engaging prefrontal cortex, the dorsal medial prefrontal cortex, that really important part of the brain, the quarterback of the mind that can now down-regulate that overactivated fight or flight response of our older brain. Here's their 60% reduction in attempt behaviors in their classic study. They have now moved BCBT onto an app that you can put on your phone. It's called Aviva, and they're using this with the military. Our VA just put out a call for interventions with pretty fat amounts of money to do research, kind of like anything could go. Almost all of it was being directed towards technology. The VA and DoD are just fascinated and bedazzled by technology. So we put in for a couple of things that were not technologically based, a little disappointing, but then it's the VA and DoD. They just love the shiny new toys that can be developed. I don't mean to mock it, and we have our own version of this that I'll describe in a moment. But I do mean to say that, I think technology is a part of the picture, and in some ways can do some very unique things. I'm a consultant to the Army INSCOM, and we have the National Security Agency up in Fort Meade in Maryland. Those are soldiers who are young and enlisted and have in very difficult jobs in the surveillance and operational work that they do. They don't want to see people like us because they may get their security clearance pulled. They may get locked out of the building if they go to Walter Reed and get themselves admitted. So technology has its place. A soldier like that is much more inclined to engage in technology than see a human provider. Mentalization-based therapy is popular in the UK, and they've got some nice data. This is Bateman and Fonagy's work. I love mentalization as a philosophical and sort of a conceptual model, looking at yourself from the outside and looking at others from the inside. It's a way of shifting perspective. Really nice data on self-harm and on attempt behaviors, hospitalizations, and secondary markers. I don't believe that there's been replications outside their group. I may be wrong. This is Guy Diamond, who's at Drexel University with attachment-based family therapy, reliably reducing suicidal ideation, but doesn't move the needle on attempt behaviors. So Guy's got two really nice RCTs, randomized controlled trials. I think there's some current replication work going on, but we're looking for independent validation of Guy's approach. It's one of the few interventions that we have been effective with adolescents, and we'll talk about children a little bit later. Now, of course, there's my favorite, which is CAMS. And so I'm going to just talk a bit about CAMS, but not belabor it, hopefully, because to me, it sort of captures, obviously, I'm biased, what I think is most essential in working with suicide risk. It is to be empathic of someone who struggles in this way. It's to find a way to get out of the adversarial relationship into a collaborative relationship. It's to talk with candor about life and death. And it really requires being focused on suicide. So in CAMS, we mean to build a strong therapeutic alliance, increase the patient's motivation. So there's a motivational interviewing component to CAMS. And what we do in CAMS that's very unique is we ask the patient, why do you want to kill yourself? And what they tell us, we call drivers. And that's what we target and treat in CAMS. So that's an overview of the model. There's a philosophy that really is meant to be sort of different, responsive to the expressed views of the lived experience community, of feeling shamed and blamed and treated as not empathically, not with thoughtfulness, not in a patient-centered kind of way. The framework for us in CAMS is to be focused on suicide. Our goal in CAMS, if at all possible, is to keep a client or patient out of the hospital, if that's all possible. So that's the expressed goal that we share with the patient. And we aspire to be flexible and non-denominational. So any theory or theoretical model could be used within CAMS. It's a framework. It's not a new psychotherapy. It's guided by a multi-purpose assessment, treatment planning, and tracking tool called the Suicide Status Form. Here's the first 4 pages that we use in session 1. The first page in standard CAMS is administered in a side-by-side seating arrangement, and it's completed in the patient's own hand. There are different quantitative and qualitative rating scales. And what you earn therapeutically by having the patient unload or unpack what it means for them to be suicidal. Who, what, when, where, how does suicide come to mind? It really carries the day in terms of what we then find out in risk and warning signs to develop an outpatient treatment plan that begins with our version of stability, which is the stabilization plan, which is the #1 problem, along with, in this case, 2 drivers, that of self-hate and interpersonal betrayal. For this patient, this is what he says makes him want to kill himself, what preoccupies his mind and his feelings when he's feeling acutely suicidal. So altogether, it takes about 50 minutes to plow your way through all this in the first session. This is our additional documentation for here in the States. This is how you get yourself to not be sued, by having robust documentation. And most of the documentation in CAMS is completed in this collaborative fashion, sitting next to the patient, and a patient gets a copy of their documentation, or they take a picture of it on their phone for their personal reference. After that first session, there's an interim version of the SSF that we do to continue to assess and continue to modify the treatment plan, the focus on drivers. And then we have an outcome disposition version of the SSF, which really completes, and bookends this very extensive level of documentation that's baked into the intervention. As we work collaboratively with the patient, where they're the expert of their own experience. So I referred to this earlier. This is the model I grew up in, where the clinician is the superior, knowledgeable doctor. The patient's in a passive position. Suicide is a symptom of major mental disorder. Treat the disorder to get rid of the symptom. And to me, this is a busted model. Still common and still vestiges of it being used around the world, but the empirical support is minimal, mixed, or none. And the dynamic is different. I know what's best for him. He's just the grateful passive recipient of my care. In CAMS, we get next to the patient, figuratively, literally, to see things from their perspective. Our goal is to see the struggle through the patient's eyes. Who, what, when, where, how are they suicidal? What does it mean for them to be suicidal? What causes your suicide? What puts your life in peril? Patients will often say depression or anxiety causes my suicide risk. If you're a CAMS provider, you say, well, what are you depressed about? And they virtually never say the lack of serotonin at the synaptic clefts of the neurons in my limbic and frontal cortex. They say, my wife is leaving me. Trauma from combat in Afghanistan. Trauma from childhood. My alcoholism. They say things that we can treat that make them suicidal. So we try to keep the patient out of the hospital if possible. We try to use a stabilization plan versus a no-harm contract, and the patient is a co-author of their own treatment plan. The licensed provider is responsible for completing the document, but the patient is fully involved and they're fully cognizant of what their treatment plan is and get a copy every session. Very different dynamic. We also know from our recent unpublished research that relationship concerns are #1. Misery and vocational concerns and self-issues are what patients describe as their drivers from 2 different randomized controlled trials of CAMS. So first session, SSF, first page completed in the patient's hand. Clinician picks up the ball here in section B and section C. Here's our stabilization plan that begins with a discussion of lethal means, different coping strategies, who to call should you be in trouble, how to decrease your isolation, and any potential barriers to attending care. After the session, we complete mental status, DSM or ICD diagnosis, and our case notes. So drivers is unique to CAMS and somewhat controversial, but also I think getting a sort of a following of sorts, because it really is idiosyncratic to the patient. What do they feel gets them in trouble? The notion of indirect drivers are what get you in trouble. Now that could be your schizophrenia, that could be your insomnia, that could be your drinking, your isolation, or getting in a fight with your partner. Those can set you up. They don't make you suicidal, but they set you up for your direct drivers to be activated. How do we treat drivers? However you want. So I would argue that some of the success of CAMS has been a success of not telling clinicians how to treat. And a lot of clinicians, especially ones my age, like that. They want to do what they know to do to treat drivers. So here's just a short list of some of the ideas that you can use to treat drivers. Every session, use the interim version of the SSF. Every session begins what we call the core SSF assessment. That's administered from the first session all the way through interim care to the last session. Pain, stress, agitation, hopelessness, self-hate, and overall risk. 3 different psychometric studies showing the validity and reliability of the core assessment. The session is then about drivers. Every session ends with a treatment plan update because drivers and interventions evolve. At the end of CAMS, we focus on increasing a life worth living, developing purpose and meaning, plans, goals, and hope for the future. We have found in a Swiss study that focusing on reasons for living in the first session is actually not helpful to the client. Later on, as things start to change, it's very helpful. So what I would recommend based on that study, 2 studies actually, is to focus a lot on the patient's preoccupation with dying, because later you can introduce the notion of why they might want to live. Resolution for CAMS is kind of different. The overall risk scale is down to a 1 or a 2. They're managing the thoughts and feelings, and they're behaviorally stable for 1, 2, 3 consecutive sessions. So we're not looking for exorcism of every vestige of suicidal thinking or behavior or feeling. We're looking for a meaningful shift in the patient's relationship to suicide. Overall risk is a 1 or 2. They're managing the thoughts and feelings, and they're behaviorally stable for 3 consecutive sessions. So this then would be the final outcome disposition version of CAMS, SSF, end of the use of the intervention. Of course, when COVID-19 came along, we could no longer responsibly sit next to the patient in this collaborative fashion. I'm proud to say in March of 2020, we immediately moved to online use of CAMS. We published a fast track paper. We now have a book chapter in a European book on telehealth. We have really seen one of the silver linings being a catapulting of us to a different level of using telehealth in the United States and around the world. We also have a form fillable version of the PDF, a form fillable PDF version of the suicide status form. And when we do CAMS online, it looks like this. So I'm a scribe, I'm completing the SSF, I can shoot this off to the EMR, I can shoot it off to him by email, and I am capturing just as he says what he says it, as he means it, and it works extraordinarily well. We had 4 randomized controlled trials going on when COVID took off. We had to flip. We have seen actually probably improved, in some cases, improved practice by virtue of different aspects of telehealth. It's not for everybody. I watched a session doing adherence work of a college student in their closet, whispering into the laptop because their nosy mother was probably standing outside the closet door. Not good. But if the environment can be made secure, if the infrastructure and the software is available, this can be the great democratization of healthcare delivery in our respective nations, especially to rural and frontier parts of our nations, which is certainly relevant to Canada and Alberta, I know. We've been negotiating with different EMRs, Guilford Press, who's not the most progressive publisher, but the publisher of my books, and really the top publisher of mental health books, in my view. I've agreed to authorizing our training company to negotiate with Epic and Cerner and the top 10 or 12, 15 EMRs. There's over 1,000 electronic medical records. But with these companies now, we're going to have the SSF built in as a default menu option, which is a great way to make it easier to use and to ensure that your electronic medical record is compliant and that your documentation is extensive and protective. I alluded to this. These are the 3 different studies looking at the psychometrics of the SSF. We know it works well with college students. We know it works well with inpatients at the Mayo Clinic. We know it works well with teenagers. It's valid and reliable, measures what we mean to measure, and does so in a consistent fashion. So the core SSF assessment is used all the way through, from first session through outcome disposition. We also know that the assessment experience of CAMS from this meta-analysis that was published in 2010 is a therapeutic assessment. So here it is in a list of 17 different assessments. Therapeutic assessments are really valuable because not only do you gather a valuable assessment information, but the patient's experience of being assessed using one of these assessments is experienced as a positive therapeutic experience. So we know that it's effective in that way as well. To get clinical trial funding, you have to have adherence. So these are the 5 major components of using CAMS: collaborative assessment, collaborative treatment planning, collaborative understanding of the patient's suicidal drivers as they define it, and how we treat those drivers, and ultimately focusing on reasons for living, plans, hope, and goals for the future. This needs updating because we now have 10 clinical trials that are not randomized. The ones with stars have comparison control groups, but we can't talk about causality, even though these trials in Denmark and in the United States and in the Menninger Clinic, for example, in Houston, were all very significant. We can't say it works in a causal way. And I have to update this slide because just yesterday we got a 6th paper. The one in the top right-hand corner, the aftercare focus study, has now been accepted for the Journal of Affective Disorders. So there are 6 published trials of CAMS, and perhaps not before this presentation you ever heard of it. I think of the clozapine example, the Meltzer study, 1 RCT, and the FDA approved it as a medication to fight suicide. The data, I think, is not backed up its ongoing use in meta-analyses. We've got tons of support for CAMS, and a lot of people have not heard of it. Some people have. We've trained over 30,000 clinicians around the world. This study here in the middle right is a German study. Great data from an inpatient use of CAMS. This bottom right-hand corner is a VA study. And I won't belabor it. CAMS reliably reduces suicidal ideation, overall symptom distress, increases hope while decreases hopelessness. Those are the big findings. The data are a bit more mixed on self-harm and attempt behaviors. In this one Danish study, CAMS was trending better than DBT, which is crazy because DBT is the best, but it was underpowered. So this apparent trending finding is not statistically significant. The German trial that I mentioned, there's a significant reduction in attempts post-discharge. So that's a really great behavioral finding. But I'm sanguine that CAMS may move the needle on ideation and may not move the needle on attempt behavior. I've shown you that there are other interventions that reliably reduce attempt behaviors. I think it's naive or ambitious or foolish to think that there's going to be one treatment that's going to work for every single patient that's ever been suicidal. But we'll get to that in a moment. CAMS is also found to be cost effective. In our Army trial, where we dropped ideation, increased resiliency, and decreased global severity. We also saw impact on ED visits, emergency department visits. We also saw that CAMS could be cost effective, thereby saving money that can be reallocated in our healthcare systems. Just kind of update you on a few of the trials as I head for the home stretch here to get to Q&A. This is the campus trial. It's a sequential multiple assignment randomized trial, or SMART design, across 4 university counseling centers throughout the nation. Big trial, lots of money. The students get either 4 to 6 sessions of CAMS or 4 to 6 sessions of treatment as usual. About 50% will respond. If they don't, they'll get more CAMS, or they'll get a modified version of DBT skills group. So this trial is now starting in about a week. We were 2 years in feasibility because of COVID. And we had a retreat at my house just this last spring, and only 3 of us got COVID-19, including me. But it was a great retreat. This is a trial that's underway. We're actually struggling quite a lot at the Cleveland Clinic and Mass General. It's a really cool idea where inpatients, older teens and young adults, would be randomized to receiving IV ketamine up to 6 doses or saline. And then before discharge, they get their first session of CAMS and 7 sessions post-discharge via telehealth. We are struggling with FDA, federal regulatory. Giving ketamine to teenagers is wrought with challenges, just in terms of statutory and IRB, institutional review boards. We're getting there, but it's been a tough trial, and we've been struggling to kind of get it off the ground, to be honest. This trial has just started up a week ago. It's a CAMS for Teen trial where we're comparing CAMS for teens versus safety planning, Barbara Stanley, Greg Brown, plus, which are telehealth visits based on an earlier study that Barbara and Greg did versus treatment as usual. This study is really exciting. It's been a hard trial to start up. Again, we have a lot of regulatory issues. Anytime you want to study teenagers, and especially children, strap on, because it's going to be a big battle with the lawyers and with people concerned about, appropriately, but concerned with regulatory considerations. And we've seen that in both these trials. We just got funded a big study, a PCORI grant, over $20 million to study ECT versus IV ketamine, with everybody getting CAMS post these somatic medication interventions before they leave that inpatient unit and post-discharge via telehealth. So that's a really compelling model for the funders, because everybody's going to get a proven, effective suicide-focused intervention. The question is, does IV ketamine or does ECT, when it works, actually enhance the effect of CAMS? Our biggest challenge in working with the teens, parents. It's just inevitable. So one of the things that we've been really working on is a protocol to not have a backdoor line of communication with the parents, because CAMS is a patient-centered focus. We want the child to feel like I'm their clinician. So we developed a very clear role for the parents, and we use a stabilization support plan, which is a brand new intervention focused on, in this case, how do the parents reduce lethal means before you meet with the child. Parents go, child comes in, and you have your first CAMS session, and then you bring the parents back in to discuss, how do the parents support the child differently? What do they say? What don't they say to be better if the child's in crisis? So this stabilization support plan is really innovative. We're super excited about it. It's baked now into these 2 clinical trials with teenagers. It will be in the 3rd edition of the CAMS book, the Managing Suicidal Behavior book, that's coming out in May. And we just shot a bunch of video about how you work with parents and work with teenagers. So more about that will be coming on our website soon, probably in October, late October, early November. A watershed moment for CAMS research was this meta-analysis showing that in terms of comparison to other interventions, so this forest plot you're looking, if you're rooting for CAMS, you want the dots to be on the right side of the ledger. The comparison treatments are on the left side. And the weighted sum of averages looks at sort of the across the studies. Significant findings for these 9 studies for ideation, symptom distress, hopelessness, and treatment acceptability and retention to care. Trending support for every other dependent variable. But there's only 9 studies. It's a lot of studies, but you typically in a really well-powered meta-analysis want 10 or more. So the data is really supportive. I'm actually okay with CAMS not necessarily reducing attempt behaviors and self-harm. Of course, I would like if it did. I think the jury's still out. We have mixed and or promising data at this point. How do we get clinicians to use a proven treatment? This is not a shameless promotion for our training company. It's just to say, you're not going to learn an intervention by osmosis. How you're going to learn an intervention is through business. God forbid business. But an integrated training model of online training, role play training, and consultation Zoom calls is actually the way to change clinician behavior. Didactic training does not change clinician behavior. So that's why I'm promoting this just as a concept, that the reason that you probably don't know CTSP and BCBT is that the founders of those interventions don't have businesses to scale them up. The reason you know about dialectical behavior therapy is because Marshall Linehan found BTEC, and that's how GBT became world famous. So we've got a training company. I'm not going to belabor it, but I will say that we've studied it. We know this integrated training model works. We know that each element of it is additive in its effectiveness in changing clinician behavior and attitudes and competency. And we also have a way to identify people as being adherent to the model. So that's all I'm going to say about it. It's important, once you develop an intervention, to get clinicians to actually use it. And that's a very challenging thing, especially people my age. One of the things I've been alluding to, but I'm just going to be outright about it, is that we tend to undervalue suicidal ideation as an important outcome. Thomas Joyner and I wrote an editorial on this topic, saying when you look at our national federal survey of suicide, your eyes are naturally drawn to these sort of colored areas where attempt behaviors occur. But I'm drawn to this 12.2 million adults who have serious thoughts of suicide in the 30 days prior to the survey being taken. That's a massive population. And we've argued that this is really an iceberg phenomenon, that what we have is this massive population. If we add the teenagers in, that's 15 million Americans. That's over 260 times greater than the number who die by suicide. And I've had papers rejected because CAMS only reduced suicidal ideation, when I've told you the other interventions don't necessarily touch ideation. So from my vantage point, the biggest challenge we face in both of our countries in terms of the suicide problem is an ideation problem. And if we were better at identifying and treating people upstream, we have fewer attempts and fewer completions downstream. So based on this editorial, I formed a research team with Thomas and others, Evan Kleinman, Sherry Johnson, Abby Mandel, and Thomas, to really dial down and focus on ideation. It's a remarkably understudied phenomenon. And pretty much guaranteed, in my country, by midnight, 130 Americans will have died by suicide. 100% of them will have suicidal thoughts on board at the moment of their death. So CAMS is being developed and used around the world. We have had some success in Canada as well, especially in Toronto and some of the eastern part of your nation. There's not a lot of competition, actually, and we're trying to develop training hubs in these different locations. So enough on CAMS for now. Just want to note that there are a lot of people who are excited about brief treatments. These are interventions that last one session, 2 sessions, or in the case of OSIP, 3 intervention sessions. Very brief interventions. In the case of OSIP, you're seeing a reduction of attempt behaviors at 2 years follow-up, 82% in comparison to treatment as usual, but doesn't touch ideation. So that dichotomy continues to exist, and OSIP is a really promising treatment. You interview a patient, you video record the interview, a narrative of their suicide attempt behavior, that you then watch on video with the patient. Each one of you has a remote to stop and make notes about what can be learned from the suicide narrative to develop a safety plan, which is the intervention. Really nice data and a number of replications going on in Belgium, 2 in the US, and I think another one in Europe, I think. Of course, technology is super hot. There are apps that are pervasive. One that I'd readily recommend is the Virtual Hope Box, developed in our Department of Defense by Nigel Bush. It's a really nice downloadable intervention that is a memory aid to remind patients why they shouldn't kill themselves. Our contribution to the technology base is Jasper Health, which is a tablet-based intervention that has key assessment and treat planning aspects of CAMS baked into the intervention. We budget 4 to 6 hours of engagement on this tablet-based intervention, and it's used in the emergency department. You can learn BBT skills. You can learn about different coping strategies. We will do assessments along the way so that when your doctor does finally show up, they get a very detailed report about your struggle. We also know that patients can download this to their smartphone for use post-discharge. We had a really robust clinical trial going on and COVID hit. We had to pull out after a third of our sample was collected. And we found a very effective intervention with just a third of our sample. Patients effectively received evidence-based interventions, significant between group differences in distress and aggression. 100% of the patients recommended it. So we are keen to replicate these findings in primary care and in the military as well. I'm going to sort of round out our discussion. I'm pretty much on time for Q&A with a focus on a classic study that you may or may not know about, which is Jerry Matos, who's a psychiatrist in the Bay Area. He's passed away a number of years ago, but he had this clever idea of taking a large patient sample of people coming out of the hospital, identifying those who refused further care post-discharge and assigning them to one of two groups. The contact group received this simple caring letter. Dear Mr. Smith, it's been some time since you're at hospital. We hope things are going well for you. If you wish to drop us a note, we'd be glad to hear from you. Signed by their attending. Sent out every 4 months for 5 years. The results showed, when they indexed coroner's records, that those that received the simple note had fewer deaths by suicide than those that didn't. And why RCTs are so important is that this group here is this group, those who sought treatment. So it kind of looks like treatment caused suicide. Oh, can't say that because they weren't randomized. But these two lower groups were, and this caring letter caused this outcome. And when Jerry's grant ran out after 5 years, the effect went away. Now, this caring contact outreach has been replicated in a number of different modalities. Here's the way that I think about it. This is our pandemic puppy, Mickey. She just ran out of my office. When we take her to the vet, reliably, she gets a call the next day. How's Mickey doing with that medication? She's adorable. We love her, but she's a dog. My wife and I take the call. This is a lovely thing to do. We should do this for humans because the data shows it can be effective and decrease attempt behaviors, even completions. It's just a sort of an obvious, simple thing to do with good data. Some of the data is contradictory. There are some null findings. There's a Iranian study that's really interesting, and some of the mixed findings are in some of these international studies. But overall, the idea of just reaching out to somebody after they've left makes perfect sense. Now, here's the problem. When we identify or study people who are suicidal and ask them about mental health care, we end up as number 4 in this one study. After spiritual practices and religious practices, talking to someone or companionship and positive thinking. Why is this? Because when they go to the emergency department or they go to inpatient units, there are, of course, exceptions. So I don't mean to offend anybody. Patients are not getting what they want. What they want is a person-centered humanistic experience. And that's not typically what they get. So we've got a problem. Now, people with experience are saying, yeah, we've got a problem. We've been talking about this now for a number of years. People are starting to finally listen to us. So what we're going to do is we're going to democratize a different kind of help by creating platforms. And here are 3 examples of US people lived experience, Ursula Whiteside, Desiree Stage, and DeQuincy Lazine, platforms for people to go, for example, in Ursula's case, Now Matters Now, to learn DBT skills. So here's the deal. We actually are in a place where those not seeking treatment is a big public health challenge. So our work is cut out for us. How do we reach these 70% of people that die that don't want us or the kind of services we provide? Public education, policy change, lifeline, text line, caring contacts, maybe if they do come to care. But we also have proven interventions. And we also could potentially use machine learning to route different patients to different treatments for whom they're best suited for optimal outcomes and saving money. What's interesting is that the mechanisms and mediators of these interventions are very similar, and they're baked into each intervention. We just published a paper in Frontiers of Psychiatry, David Rugg, Craig Bryan, myself, some others, that what we see is common across the RCTs of suicide-focused interventions is quite unifying in terms of these constructs of stabilization planning, lethal means safety, and how we reach out and support our patients. So we are, in fact, at a time when we can match different treatments to different needs. The lived experience support base is novel, and we got to study to make sure it works. There's a guy at University of Michigan that's studying that very thing. But before it works, I'm not going to be advocating it. We do know that one size doesn't fit all. This is a paper that we published online. This is Ron Kessler. He took our Army sample and noted in a machine learning algorithmic way that 82% or 72%, 78% of the soldiers in our sample would have benefited from CAMs. 22% would have benefited from treatment as usual. So it's an example of precision treatment rules driven by machine learning algorithms that causes, to me, great hope for the possibility of what we might be able to deliver. So one of my final slides, we need a massive workforce. What we actually need is a mental health service corps. For us Americans, it'd be like the Peace Corps. but it would be personed by people with lived experience and college students getting loan forgiveness who could do things like safety planning and lethal means safety discussions, who could person our national lifeline that's overprescribed. We have interventions that we know are effective, that could work at each level. And on the y-axis here, we have expense and money that drives that tail wags the dog of a lot of what we're able to do. CAMS does a bit of everything to deliver suicide-focused evidence-based care that's least restrictive and actually cost-effective. 988 is here. We are not ready. So this gentleman who we saw in our first slide, this was not his day to die. And his name is Kevin Berthia, giving an award to this gentleman here, Kevin Briggs, who was a CHIPS highway patrolman whose beat was the Golden Gate Bridge. Kevin reckons that he's probably saved over 300 lives and maybe lost 20 to 30 on that beat. It's a moot point now because finally, after 5 different legislative initiatives, there is now a netting system that will capture people jumping off the Golden Gate. So it's an example of lethal means restriction. It's an example of what we're able to do, even without training, if we're decent human beings connecting with another human being who's struggling with their life. So with knowledge and collaboration and collaborative engagement, we can all help save lives. So these are the people that make my world go round. My research mentor, Marshall Linehan, my other research collaborators, my lab, my wife, Colleen, who's at the heart of everything I do that's decent or good, are all the people that make this work possible. And with that, I will stop sharing my screen and we can hopefully transition with Dr. Jansen to Q&A.
I want to thank you very much, Dr. Jobs, for that amazing presentation. I really enjoyed all of that information and definitely got my wheels turning. And I know it did for the rest of our members, as we've got a lot of Q&A that have been popping up. So I think I'll just dive right in, if you don't mind, to go right into some of the questions. So some of the initial questions are really focused initially on assessment and some of your comments on assessment. And they're kind of looking at where the nexus of suicidal ideation becomes intent and why you think that we don't have a good bead on prediction with that assessment. Yeah. If you'd say a bit more about that.
Yeah, it's super hot, Troy. What I can tell you is in the UK, they developed NICE guidelines that then inform the NHS system. And they have explicitly and rather aggressively been saying, we can't predict future behavior, which I've argued we've known since like the 1970s. It's a low base rate phenomena. George Murphy published a paper in 1974 saying we can't predict suicide, but we can talk about different kinds of risk. I'm afraid that my British colleagues and some of the folks in Australia have kind of gone off the deep end with this and saying, we can't predict risk, we can't predict future. And that is, to me, that's not even a debatable point. It's just too rare. So we're going to be much more wrong than right around this rare phenomenon. So what I am doing now in the 3rd edition of my Guilford book is shifting the whole debate from predicting future behavior to a much more trainable and objective notion, which is stability. That if I'm talking in my country to a middle-aged white male who's a gun owner, alcoholic, who's made 3 previous attempts and is highly dysregulated, and his wife has just left him, I'm very concerned about that person's potential inability to be stable. And that might be somebody, even me, who's pretty much not keen, might hospitalize that individual if I'm not able to negotiate a decent stability plan. And so what I'm advocating now is a 5-level assessment of stability, where your concern for the patient's stability is either none at all to extreme. And so I'm trying to change the conversation from low, medium, high risk, which the Brits say you cannot do. I think they haven't really offered an alternative. Now what they're saying is, well, you can do conceptualizations, you can do management, you can do patient-centered work. It sounds a lot like CAMS to me, but they won't say that. So there it is. We want to predict it, of course, but it just statistically is probably impossible. It's where machine learning seems exciting and also frustrating, because even with the massive database that they use, they're more often wrong than right.
Thank you for that answer. My follow-up to that would have been, the common clinical wisdom for most of us in our training was that you ask for several key questions like, are you thinking about it? Do you have a plan? Do you have means? Is anyone else committed suicide? And substance use?
Yeah.
So are we saying that those are invalid any longer? Or
no, in fact, you just described the first 5 variables in section B of the suicide status form, essentially. So in when we do CAMS, we go through the first page, which is different kinds of quantitative and qualitative assessments. And then we move to section B, and it's, do you have suicidal thoughts? Do you have plans? Do you have access to lethal means? Do you have 2 or more attempts? Just as a matter of actuarial fact, anybody that you see with 2 or more attempts is significantly much more at risk than somebody who's only ever ideated. So yeah, no, those variables still count. I think one of the things that happened, Joe Franklin at Florida State University did a meta-analysis of 50 years of risk factor research and showed that risk factors don't predict anything. It's like flipping a coin. It's barely better than chance. But you don't throw the baby out with the bathwater, in my view. That in all the excitement and the op-eds to critique risk assessment in this low, medium, high way, what's been lost is that clearly there are different kinds of people. They're not all the same. And that's why I try to drum home this idea that we have different kinds of states and different treatments for different states.
Very good. Okay, thank you. Someone asked if you would clarify the index card safety plan. Who was it that created that? Just so I think they want to be able to look that up again afterwards.
Yeah, Barbara Stanley and Greg Brown.
Barbara Stanley and Greg Brown.
Yeah, if you just Google safety plan intervention or Barbara Stanley and Greg Brown, you'll find that a lot of the stuff that I'm talking about, like the ASQ, totally Googleable. So Google it, and there's usually some sort of guidance as to how you use those kind of instruments.
Terrific. The next question, I'll just switch to a little bit more to intervention focused questions. There's a question here on the therapeutic alliance. So, you're talking about removing or decreasing lethal means through utilization of therapeutic alliance, and they're seeking a little bit of your sort of perspective on, what's the right strategy? Are there questions to ask? Or what's the collaborative strategy with family?
Yeah, I love that question because I mean that's why CAMS got developed. Basically, was the idea of, I think a lot of providers, to be candid, are like, how do I get rid of this patient? And patients sense that. Where in CAMS, I not only am I saying, how do I not get rid of you? How do I keep you as an outpatient? And can we kind of join forces? What I would say in the dynamic of CAMS, you start to sort of drop in a shared assumption, which is, of course, we want to save your life. Why wouldn't we want to save your life? But if we're going to save your life, we've got to develop a really thoughtful stabilization plan, and we've got to treat the things that make you suicidal. So the meta-analysis finding that I'm most excited about, that 9-study meta-analysis, is that CAMS reliably increases hope and decreases hopelessness. It's the biggest effect size. And I love that scientific finding most of all, because to me, that's always been the secret sauce in effective care, writ large, and also then specific to suicide risk.
Excellent. Actually, I have a personal follow-up question. You mentioned that generally the poorest track record is inpatient hospitalization. And I wonder if you have any speculations on what accounts for that. I know that we've tended to go that way to protect ourselves when we're worried for that. But what accounts for why that's not effective? Is it just that they aren't employing that? Is it the lack of training? What would you say?
I would say, from my bias, it's not suicide focused enough in its care. So, for example, in this German trial in Bielefeld, Germany, there's a doctoral dissertation of a young psychologist there, and she had a 12-session version of CAMS on the inpatient unit, and the treatment, as usual, was actually quite good. It was a structured, supportive treatment, and she got significance on everything. The paper's now under review, and we're hoping to get it published because the alliance was stronger. The overall symptom distress, ideation, all the typical findings that we have, plus this discharge, post-discharge data. So I would say this. I had the brother of a US veteran call me and ask if I could consult because he and his mother was considering suing a psychologist. It was a really heartbreaking story of a war hero, basically, who was special operations, and he left the Army to go into like private security. He got depressed, he drank too much, he was hospitalized for 10 days. And on the day he was discharged, he went home and shot himself in the head. And the brother was enraged. You know, how could this be possible on the day he was discharged? And we talked about it, and he said, well, all he did was sit in the day room and talk to other patients, watched a lot of TV. He saw a psychiatrist maybe 2 or 3 times. I think he was in some groups, but it was not helpful. It was actually probably contributed to his hopelessness, because the bill was like $20,000 for a 10-day stay. So my concern is that if there's not, you know, that's why I like Marjan Holloway's intervention, the PACT intervention at Walter Reed, is you get the cognitive therapy intervention for a 7-day stay. You're actually getting something that post-discharge actually makes a difference with regard to suicide risk. So I'm not anti-hospitalization per se. I'm just anti-hospitalization that doesn't sufficiently focus on suicide.
Excellent. Thank you for that answer. Now, I know we're about 4 minutes left, so I want to make sure that everyone knows that we're probably not going to get to all of the questions and answers. There's some really excellent questions on here. The next question I do think is important to raise, because we are seeing an opioid crisis in many places in North America, increased with COVID. And the question was, you know, are opioid-related deaths and the data on suicide and maybe the conflation of those things, and what are you seeing, and how do you sort of tease out those kind of situations?
Yeah, excellent question. The RAND Corporation here in Washington did a pretty convincing study that the drops in suicide over the last 2 years can probably be accounted for by opioid overdoses, and that those are probably disguised or undetected suicides. The other thing that was alluded to early on in the introduction is that we have seen marked increases in depression, anxiety, substance abuse, and especially in my country, and I'm probably thinking in Canada as well, especially among young people of color. And we've seen in our Indigenous populations rates that are typically like 3 times the national rate, and insufficient focus. I think Canada actually, in my view, has been much better in their focus on Indigenous populations than the US has been. We're catching up a little bit, or trying, but it's something that's plagued us for years and been long ignored.
Thank you. Yeah, I mean, I would say that we have a lot of work to do in our nation in that regard as well. But certainly, there's still a crisis of suicidal risks in First Nations communities in Canada. And then I'll just quickly try to fold a few questions into one here. Some have asked some questions about young children. A lot of the research tend to focus on teen adults, but we do know that there is suicide risk for young children. Yep. And maybe some specific comments about that, or unique populations like those who have auditory visual hallucinations, obsessive compulsive desire to die, things like that.
Yeah, I used to say that exclusion criteria for CAMS was children or psychosis, until people started using it with children and psychotic patients. Actually, the SSF is actually, I think, very helpful for psychosis because it's very grounding. And a lot of patients we've seen with severe SMI have really benefited in the VA trial that's going on right now. We do have a feasibility trial with 4 to 11-year-olds at Nationwide Hospital in Columbus, Ohio. It's a highly modified version of the SSF, where the children are pointing to faces in their rating scales and they're doing drawings. 6 months, the lawyers at Nationwide and my university debated about whether they would let us see 10 kids. So I don't mean to be cynical, but there's just a lot of anxiety and nothing. There's only been one book in the field focused on the suicidal child by Cynthia Pfeffer in 1985. And we know that kids have these thoughts, and that roughly 30 to 35 in the States die every year. But there are some medical examiners and coroners that won't even certify a child under the age of 12 as being capable of dying by suicide. So it's a hugely needed focus.
And the last question, I'm right out of time, and I want to give everyone a body break before our next panel presentation. But many have asked, where can they get additional training, either in the CAMS or and you mentioned you have a website. So if you want, is there a way that they can be directed to that?
This is a shameless self-promotion, cams-care.com, and all of our training is now online. And we really try to accommodate, especially students and young people who are less inclined to not change. So CAMS Care, and then BTEC, there's a number of DBT training organizations. There is training also at the Beck Institute, but not reliable training in the cognitive behavioral approaches, but they're very good. Hopefully those will come online one of these days pretty soon.
Well, that wraps up our time, Dr. Jobs. I really appreciate your time, willingness to stay and answer a few questions. There were many we didn't get to. I think there were 50 questions total. I apologize to anyone I didn't get to. We do have our panel getting ready. I want to give everyone a break, but I wanted to thank you personally for the time you've spent with us today. Fascinating topic. I think we can't get enough of those questions answered. But I would encourage everyone to take a look at the presentation materials, the research that Dr. Jobs presented. I think there are a lot of answers in that that we didn't get to today. So thanks once again, Dr. Jobs. Really
I appreciate the really kind comments, and thanks so much for having me, Dr. Jansen.
Excellent. Well, thanks so much. And I think we'll take a little break now. And I think that our Matchbox people will let us know how to transition to the next phase. So thanks again.
Thank you, Dr. Jobs. We thank you for taking time to share your experience. Your keynote presentation was thought-provoking and informative. We will now have a very brief health break before the panel presentations begin at 3 p.m. At that time, Dr. Troy Jansen will assume moderator responsibilities and lead the rest of the afternoon.
Thanks so much for having me.
Thanks and goodbye, and have a great day in Washington.
Yeah, you too. Take care.
Okay, thanks.
Bye-bye.
Bye-bye.